So let's, without talking about anti-VEGF agents in particular, let's just talk about different dosing regimens. Dr. Boyer has already said that he uses a treat and extend regimen. Is there anybody on the panel who uses just a strict labeled, either monthly or every other month dosing scheme?
I don't. I mean, I do, as David alluded to, a one-eyed patient who had a hemorrhage in the one eye and lost vision and has good vision to begin with. That's maybe the one case where I tend to be very aggressive and go almost on label, maybe out to every 6 weeks at most, but I try to stay aggressive and don't go to a more PRN or treat and extend protocol. But the routine patient who is coming in or out, I try to do something that's beyond just every month or every 6 weeks.
But I think a third of my patients fall into that category of they have disease in the fellow eye with poor vision, and they don't necessarily have to have a submacular hemorrhage, but those patients I probably have on somewhere between a 4 to 6 week period. Now, it might be also that every time I extend to 6 weeks, they leak, and they may be so brittle that if I go to 5 weeks, they're okay, and at 6 weeks, they're leaking. But I feel it's important not to let them get to that stage.
Well, I think this is a very important point, because if we look at the CAT study, in particular the second year of the CAT study, I think that study very conclusively showed that monthly was better than as needed. So are we as retina specialists undertreating, or do we not believe that study?
I think the more we get out, the more we realize we undertreat a lot of patients. And what I mean by that is after Marina and Anchor, we really thought after 24 shots, people wouldn't need more shots, it'd be done. And it doesn't matter. There's people that need monthly shots at year 7 and year 8 and year 9. And every time we try to extend, and I do, I think you run the risk of letting some of those vision gains that we saw in the curve slip away. If you look at what's the risk of treating somebody, it's the risk of endophthalmitis, about 1 in 3,000. What's the risk of hurting somebody? PRN therapy makes your curves go away. I mean, you lose the gains. So we hope with treat and extend, you're somewhere in between those two curves. If you have very few excursions and few leaks, hopefully you're very similar to monthly. But it's tough to design a treat and extend protocol that proves that.
Well, and the 7-Up study, so the 7-year follow-up of patients in Anchor and Marina, when they were eventually just followed PRN over a long period of time, a third of those patients were 2,200 or worse after 7 years, whereas after the 1 and 2 year trials of monthly, less than 10% of patients. So we clearly do not have a long-term strategy in place for a third of patients, and that's, I think, one of the greatest challenges with anti-VEGF therapy is how do we not think of the short term, 1 or 2 years, most people do well, but how do we then get those patients out, we're maintaining good vision at year 6, 7, 8 on down the road, because that's really where a lot of patients, now that we've been using anti-VEGF, especially Lucentis, and Avastin for about 6 years now, 6, 7 years, we're seeing a lot of patients who then slowly are losing visions in that 5 to 7 year framework. And that's where I think that some of these early decisions we make may have repercussions down the road.
But I also think in that study, the other thing that was really surprising is after 7 years of treatment, 50% were active. They were still receiving treatment. They still had active leakage. So, I mean, we're not curing this disease. We're just, halting it for some period of time. And I think the other thing that it showed was the amount of pigment alterations that we're seeing. So periodically, I think perhaps doing autofluorescence or fluorescein may be helpful to see if you're getting disease progression, as you pointed out, from the choroidal neovascularization or with the autofluorescence from geographic atrophy.
We have a few patients dating back to the original multi-injection Lucentis study, so we're talking 2001. And the ones who are still getting some degree of regular therapy, there's one patient who was in the very first batch. He's a sculptor. In the middle of the study, his fellow eye developed wet AMD. We couldn't treat him with Lucentis at the time. That eye's 2,400, but the eye in question is 20/30 still. He's still a sculptor, but he gets treated very regularly. He had one gap where we started not treating him. He had been 20/20, and he lost some vision. Now, the other problem is there's non-exudative disease that's also ongoing, and patients lose vision from that as well, and sort of separating the two can be an issue.
Well, and that's an interesting point, because in the CAT 2-year data set, they indeed pointed out that the patients receiving Lucentis monthly had larger amounts of geographic atrophy and larger enlargement, or greater enlargement of geographic atrophy. Dave, do you think, Dave Brown, do you think this is a real finding? Is this, what do you think of that finding from the CAT 2-year data?
You don't have any other choices. I mean, you can let them go blind from wet macular degeneration to try to save some non-foveal geographic atrophy that didn't hurt the visual acuity if it's real. I don't think that it's likely to be real. We haven't seen it in the DME trials. We haven't seen it in the RVO trials. And we don't think we've seen it much in patients we've been treating since, the last 10 years. It's you run a reading center. It's easier to diagnose geographic atrophy on a color photo when there's not fluid and hemorrhage and active disease over it. So the fact you find more when you drop the patients after a year may be an artifact of the way they're doing it. It'd be nice to see autofluorescence, OCT, other entities demonstrating that in not only CAT, but every other study we have, Harbor, the View 1, View 2. We've got lots of other anti-VEGF data out there. I would like to see that replicated before I put a whole lot of credence in it.
But do you think, you alluded to the fact that you measure the choroidal thickness at baseline, do you think that that has any play in this development of GA, and that patients who come in, we know that patients who come in have a spectrum of choroidal thicknesses when they develop CNV, and so the question is that playing a role in some cases to the adverse effects of anti-VEGF? Patients who have thin choroids with CNV are maybe more susceptible to the development of some GA with anti-VEGFs. Do you think that's a future place where we should be putting more focus on?
It's really surprising when you look at patients with geographic atrophy. There are patients with geographic atrophy with really robust, healthy choroids. And you have patients with almost no choroid where their RPE looks solid. And so there's certainly not a linear correlation.
I think if we look at anatomic effects of these treatments, I'm far more likely to think that the persistence of fluid is more likely to have a long-term effect than the development of geographic atrophy. That may turn out to be wrong. We over time will see these, but certainly it seems as if in most of the studies, in series, in our own anecdotal experiences, undertreatment seems to cost more vision than overtreatment.
Now, if you had an effective treatment for malignant melanoma of the skin, but it created prostate cancer, okay, should you let patients die in 6 months of malignant melanoma to prevent prostate cancer 10 years later? That's essentially what you're talking about. We've all got patients 7, 8, 10 years out seeing well. We do need to figure this out. If we're hurting the RPE, we need to figure out if does one agent do it more than others. Is there ways to mitigate that? But until we have other evidence, it does not concern me that there was small amounts of non-foveal geographic atrophy seemingly increased in one cohort of the CAT trial. Does it bother you, Peter?
The geographic atrophy, I'm still unsure that the GA that was seen in the CAT study was truly due to Lucentis being given monthly versus just sort of spurious statistical finding. They didn't look at the data at baseline to really be able to say that it changed. Was there a baseline in differences? For instance, your point about the fact that when you have a wet macula, it's very difficult to image geographic atrophy is a very good one, because the Lucentis monthly also had the driest macula. So I think it's an intriguing finding. What I was going to ask you is, was it seen in Harbor, or Jeff, was it seen in View? I mean, these are studies, long-term studies, and especially in Harbor, you're doubling the dose or quadrupling the dose of Lucentis. You'd expect to see more atrophy in those patients if this was truly a finding due to that.
Yeah, that data has not come out of the reading center yet. The 2-year long-term data of GA sizes. It is something They did some autofluorescence, but it wasn't standardly used either. I wish it was.
And I think it's a similar situation with view. And you keep in mind there are different readings. So you could try to look at it with OCT in cases where maybe you didn't have autofluorescence or where the imaging is difficult because of the fluid. But I think the bottom line is that it's very hard to assess when you weren't looking for it at baseline to really analyze it.
It's hard to assess on OCT too. We've used some of the tools and some of the OCT software that in pure dry GA seems to really measure geographic area. And we looked at it in the SAVE trial where we had a population where all these patients had monthly OCTs, use that same software and it's a random number generator. Because it's so hard to get, through the fluid, through the hemorrhage, through the thickened lesions, a reproducible signal to grade. And we were disappointed. Maybe it works better. And Grigori has some experimental versions that are beyond what's in the current software.
And actually, View had Stratus.
Yeah.
So we're not going to
But the caveat to that was the main reason people got to 2200 or worse in both Anchor and Marina was the development of GA.
Yeah, I agree. I think in my mind, a GA issue is really one that we need to watch closely, and in future clinical trials, we will have to prospectively follow for it. But I'm not convinced yet that any of our anti-VEGF agents really produce GA.
And I think to Dave's point, at this stage, would you in any way, shape, or form not treat a patient based on it?
Exactly. I agree fully.